There's a lot of talk going on today about the difference between prepectoral breast augmentation and retropectoral breast augmentation. Basically, the question is not so much the implant, it has to do with the surgeon and the technique that they're using. If you go way back 20, 30 years ago, we were using largely saline implants. When you were using just a saline implant, one of the downsides of it is that it ripples. And the best way to cover up that rippling was to put the implant up underneath the pectoralis muscle. So that would be called retropectoral or subpectoral implants. And if you go on Google and look, you will find a tremendous amount of evidence out there for putting implants in the subpectoral space. And that's largely because we were doing this for decades, back when silicone implants were off the market. In the mid-2000s, the FDA cleared silicone implants for use across the market. There were some very specific requests that they had, and one of them was that the patients follow up with their surgeon and have evaluation with an MRI every 2 to 3 years, and that could look for something called a silent rupture. It's a slightly different topic, but what this means with the advent and the reintroduction of silicone implants back into the market about 20 years ago is that now we had implants that performed more like human tissue. And with an implant that's performing more like human tissue, it could go in front of the muscle because you didn't have this rippling challenge anymore. As you look at the anatomy of the breast, you have breast tissue, you have a layer of fascia, and then you're down to the pectoralis muscle. Underneath the pectoralis muscle, you're at the chest wall. One of the things that we were able to do starting 20 some years ago was to use the technology of these silicone implants and put them in front of the muscle. So this is called prepectoral, but we would put it underneath the fascia, and the fascia would help control the implant so that it was not in the gland tissue of the breast. This was a fantastic innovation. One of the really big parts of it is how much less uncomfortable and how much less painful this technique was when you were putting the implants in front of the muscle. So one of the big differences in terms of animation is with the implant in front of the muscle, there is no motion of the breast when you move your arms. When the implant is behind the muscle and you're moving your arms and flexing, you will see the breast move, and that's called animation deformity. I don't like the term deformity because it suggests there's something wrong. It's not wrong. We have been using the muscle to shade and to sort of disguise the ripples on the implant. That's why having silicone implants, which have been back on the market for over 20 years now, have been so incredibly successful to be placed in front of the muscle because they have very little rippling, and quite honestly, these implants perform and act and look a lot like human breast tissue. There has been a huge explosion with a new implant company called Motiva, and what they're advocating is this technique called preserve. Their technique uses a balloon for the dissection. So you make the same incision at the inframammary fold and you dissect in this tissue plane and you inflate this balloon. And so their concept is that it is more atraumatic in terms of dissecting the pocket through the volume expansion of this balloon. It's a great technique. There are a lot of advantages to it. But really what it's done, it has shown a broader spotlight on the prepectoral implant placement, which again has been going on for decades. And it is great to see more innovation coming in with new techniques to be able to deploy this in that prepectoral space. But really the big advantages of putting an implant either in front of the muscle or behind the muscle have to do with the animation deformity, have to do with the discomfort afterwards, because when you go up underneath the muscle, it is quite uncomfortable and patients will feel like they were in a low-speed motor vehicle accident for several days after surgery just because of the pressure and tightness on the chest. There's also a significant amount of settling that goes on in terms of that implant dropping down after it's placed up underneath the muscle. We don't tend to see this nearly as much when you go in front of the muscle because you're picking your pocket, you're doing your very delicate dissection, and you're delivering that implant pretty much to where it's going to be for the duration. Some of the other differences between retropectoral or subpectoral implant and prepectoral is the ability to do this under local anesthesia. This is something that I've been doing for over 10 years, putting implants in underneath the fascia, in front of the pectoralis muscle. It's something that can be done very straightforward under local anesthesia. So the patient's sitting there talking with you through the entire operation and in a very, very comfortable state because of numbing medication that you inject into the area. They get a few pills of oxycodone and some Valium so they're comfortable. And then some tumescent fluid. Tumescent fluid is the same sort of fluid that we would use in a liposuction procedure, and that is injected and infused into the tissue, again, just above the pectoralis muscle and below the breast tissue, and it expands that tissue, and it does two things. One, it delivers numbing medication so the patients aren't feeling any discomfort. And then number two, it has some epinephrine in there so that as you're doing the surgical dissection, there's virtually no bleeding, which is very significant in terms of creating a comfortable postoperative experience. So I hope you found this helpful, the difference between prepectoral and retropectoral and how this all comes together with the new techniques that have been described as the Preservé techniques. I hope you found this helpful.